Welcome, everyone. My name is Sophia Greskin, and I direct the Institute on Inequalities in Global Health at the University of Southern California. It's my great pleasure to welcome you to HIV/AIDS and the Longevity Dividend, Strengthening Health Systems and Advancing Equity in Aging Societies. Today's policy dialogue on how the U.S. and other governments can work together to strengthen health systems as individuals and societies grow older, particularly through our longstanding support to HIV and AIDS programs. Today's dialogue lies at the intersection of two of the greatest public health challenges of the 21st century, ending AIDS and the long-term effects of AIDS on people living with the virus, as well as adapting our global health systems more generally to meet the needs of aging populations. And I just to give a bit of context for the panel, in 2020, there were over 8 million people aged 50 years or older living with HIV around the globe. And that's up from about 5.4 million in 2015. So to be clear, the population is increasing, both because young people with HIV are surviving and aging, but also because an increasing number of older people are acquiring HIV. So what's important here is to remember that there is great diversity in these populations, and therefore in the health issues that are particularly salient to their lives. For example, with women aging with HIV, face an increased risk of cervical cancer that's associated with HPV, as well as biological vulnerabilities linked to HIV after menopause. And it goes without saying, I think, to this crowd, the sexual needs and rights of older women and older women living with HIV specifically have to be recognized and addressed everywhere in the world, and that's regardless of marital status or sexual orientation. And similarly, amongst lesbian, gay, bisexual, and transgender men and women, again, in all corners of the world, over the course of their lives, discrimination and inequities in access to needed physical and mental health services can result in wear and tear on people's bodies, and through this create higher risk of life-threatening diseases in older age. So clearly, all populations have a right to enter their later years at no greater risk of HIV and its impacts than anyone else. And so that's why the panel today is so important, and why it is that we need the tools of equity and of human rights to shape the responses that are going to help everyone to live longer, healthier lives. And so I really want to thank our speakers very much for joining us today and for being in dialogue on these and other critical issues that relate to aging and HIV. You're joining us at a moment of immense opportunity with the reauthorization of PEPFAR, occurring at a time of longer life expectancy, due in no small part to the success of HIV treatment programs. And I'm looking forward to how you all are going to help us understand and make the most of this opportunity for everyone. And so with that, I'd like to turn it over to our wonderful moderator for today's event, Professor Jonathan Cohen, who is our Institute's Director of Policy Engagement. And the thing to say about, well, there's a lot I could say about Jonathan, but one very specific thing is that he convenes our regular policy dialogues and leads our work in Washington, D.C. And I do have to say, we're thrilled to be expanding this work with the opening of the USC new Capitol campus in DuPont Circle this year. More on that for another time. And with that, Jonathan, over to you and to this wonderful panel.
Thank you. Thank you very much, Sophia. And I am especially grateful to you for framing this issue as an opportunity. I think too often issues of aging get framed as a burden or a crisis, when in fact they are an opportunity. We're going to be spending a lot of this panel talking about the African continent, where the US government invests most of its global AIDS account through the PEPFAR program, through the President's Emergency Plan for AIDS Relief. And while Africa is often described demographically as a young continent, the reality is that the over 60 population is increasing there, and demographic projections show that chronic diseases associated with aging pose a high burden there. I think in the United States, we often make the mistake of casting these projections as a threat to our health system, as something that's going to overwhelm Medicare, when in fact we know that older adults bring tremendous assets, bring tremendous capabilities and leadership to our country. And moreover, that the kinds of health system transformations that are needed to meet the needs of older adults with comorbidities are ultimately going to benefit people of all ages. So I really do appreciate the spirit of opportunity, Sophia, that you've established at the outset of this session. Speaking of PEPFAR, I have the distinct pleasure of introducing Congressman Ami Bera, who has provided some remarks to open our session today. Congressman Bera, or should I say Dr. Bera, represents California's 6th District in Sacramento County and is a senior member of the House Foreign Affairs Committee, which has jurisdiction on the House side over PEPFAR. Representative Bera serves as chairman of that committee's subcommittee on Asia, the Pacific, Central Asia, and non-proliferation. And he is also a member of the House Permanent Select Committee on Intelligence and the Select Subcommittee on the Coronavirus Pandemic. He's also a member of the New Democrat Coalition, which is a group of over 100 forward-thinking Democrats who are committed to pro-economic growth, pro-innovation, and fiscally responsible policies. So Caitlin, please run the welcome from Congressman Bera. Thanks.
Hi, I'm Congressman Ami Bera from Sacramento County, California. I'm also a physician and someone who works on global health security within Congress. I want to thank USC for your work on addressing inequities in global health and for allowing me to make a few comments on why PEPFAR has been such a successful program. In fact, it's been one of our most successful programs in the history of our country. Was recently traveling through Africa this past summer and had firsthand been able to see the impact of PEPFAR. That's why it's so important for Congress to reauthorize a clean 5-year funding bill. When you talk to folks that have been impacted by PEPFAR, who have been able to receive antiretrovirals, it's saved tens of millions of lives. Again, that's why I'm doing everything I can within Congress to make sure my colleagues understand the impact, understand the well-being that comes from programs like this and the diplomatic relations that this gives us within the continent of Africa. Now also, the conference is going to address aging and inequities. And as we've been so successful addressing HIV and AIDS through programs like PEPFAR, we're also seeing many of those individuals whose lives we've saved aging now with normal chronic diseases like diabetes, cardiovascular disease, and so forth. We've also got to double our efforts through aid and development, working in country to build up those assets and address those needs that are unique to HIV AIDS populations that are also older. So again, thank you for your work. Thank you for hosting this conference, and thank you for allowing me to say a few words. Be well, be safe, and let's be kind to one another.
Thank you, Congressman. Really grateful for your leadership, grateful for the sense of urgency, as well as the both political and medical perspective you bring to this issue. We are going to proceed with a dialogue with 2 leading experts on HIV and aging from Eastern Africa, from countries Kenya and Uganda that benefit significantly from PEPFAR, Dr. Chirchir or Chiri Kiplagat and Dr. Stephen Watiti. Dr. Kiplagat is a lecturer at Moi University School of Public Health, and she's the Associate Director of Research at AMPATH, Kenya. She's a PhD graduate from the School of Public Health at the University of the Witwatersrand in Johannesburg, South Africa. Chiri's PhD work focused on HIV and aging and identified key challenges facing older adults living with HIV that need consideration in the fight to end HIV by 2030. She holds a master's degree in public health from Moi University and an undergraduate degree in environmental health from the same institution. Welcome, Chiri. And Dr. Stephen Watiti is a medical doctor, an HIV activist, and an ardent advocate for improved and sustainable health for all in his native Uganda. He studied medicine at Makerere University in Kampala and went on to become a medical officer at Rubaga Hospital from 1985 to 1988. He practiced medicine privately from 1988 to 2004, and also worked at Mildmay, Uganda, which is a leading HIV and AIDS service organization. Dr. Watiti has himself been on antiretroviral treatment for HIV since 2000 after contracting multiple opportunistic infections, and believes that he acquired HIV as early as 1985 or 1986. He currently advocates on issues related to HIV and aging, including through his weekly column on HIV in the New Vision, Uganda's leading daily newspaper, and he has 2 published books on HIV as well. Welcome to you, Stephen. After a short dialogue with both of you, I'm going to invite our third speaker, Dr. Katie Godfrey, to give a short slide presentation about aging in the context of PEPFAR. And I'd like to introduce Dr. Godfrey now. She's an infectious disease physician with extensive experience in HIV, tuberculosis, and sexually transmitted infections. She is the Senior Technical Advisor for Adult Care and Treatment at the Office of the Global HIV and AIDS Coordinator at the Department of State. And she leads several high-profile work streams, including PEPFAR's response to COVID-19, mortality in the PEPFAR cohort, approaches to interruptions in treatment, infection protection and control, as well as differentiated service delivery for adults. She has published extensively on treatment issues for people living with HIV and is the recipient of awards which reflect contributions to women's health and to the HIV-affected community. Welcome, Katie. I think you will all agree that we could not be joined by a better and more distinguished group of panelists to be in dialogue with on this critical issue. So as I said, Chiri and Stephen, I'd like to begin with you. And I want to ask you both the same question. And I'll invite Chiri to answer it first and then Stephen. And my question is, what was the first experience that you had, either a personal experience or a professional experience, where you understood or came face to face with the links between HIV and AIDS and aging and healthcare systems? Chiri.
Thank you so much, Jonathan. And I appreciate all the panelists as well as the participants today for joining. I want to go back to 2007. Are you hearing me? Sorry, okay, cool. In 2007, I was a research assistant in the AMPAT program. As Jonathan did mention, I've been working in the program since then to date, nearly 15 years now. Within the program, I joined in after my undergraduate degree, and one of the roles as a research assistant that I was doing is going to the medical wards to really review inpatient data. And in the process of reviewing inpatient data, then we would assess, mortality and morbidity related to HIV. This work at the time then would require that I go into the wards, look at the, medical records, assess who is a newly admitted patients. Among the new admitted patients, how many of them have been tested for HIV, how many have been admitted and they were already known HIV, people living with HIV. And then at the end of the day as well, I would go back to the wards to look at the files to assess how many of those who were tested turned positive, and how many were discharged home, how many, died, because the part of the whole work was related to mortality and morbidity. So one of these days, while looking at the files, I missed one file. And of course, you just go through the files to assess, the new admissions and those who've been tested. And this was an older patient. I've talked about this severally, and that is where I got interested in older adults. This was a 78-year-old woman who had been in the wards for nearly a month being tested for, being treated for other, diarrheal conditions. She had oral thrush. And my belief is that healthcare providers, assume that these are old age conditions, and likely no one thought about testing for HIV until this one time. Actually, the testing was done as part of diagnostic testing and counseling. And this lady was found to be positive. To me, it was one thing. Even old people actually get HIV or are tested, got tested positive for HIV. And I kept wondering how many other older people are missed out as a result of, the assumptions that older people, are not, susceptible to, getting infected with HIV. How many other people come seek healthcare? They are treated for the conditions that they've come into the clinics, but then, go back home. But in real sense, you're missing the HIV infection that probably would, be mitigated early enough before it actually becomes, goes way into the late stages. That's the interesting part that, got me hooked to HIV and older people. And it's what led me to doing my PhD in 2016 to look at what are the challenges older people face, living with HIV. And in real sense, there were key challenges that these people face. And one of them that I want to highlight before I leave is the issue about comorbidities. That HIV care has been well established. There is, it's well funded, including provision of medication. The clinicians who provide HIV care have perfected in that area, and as such, issues related to other comorbidities that they develop as they age becomes, a huge burden to the patient herself or himself. I don't know if I've gone past my timing at this point, but I want to leave it at that point. Thank you, Jonathan.
Thank you so much, Jerry. What you're describing, it feels almost like a kind of triple jeopardy, where first, you're not tested for HIV at a certain age, probably due to some combination of ageism or stereotyping or assumptions that you're too old to have it. Then you are tested and you're already experiencing late stage opportunistic infections because the test happened so late. Then you develop comorbidities and the health system isn't equipped to deal with those along with HIV. And this is a common experience. So thank you so much for sharing that. Stephen, what about you? What kind of personal experience brought you face to face with these issues?
Thank you very much, Jonathan, and thank you all colleagues. I hope you can hear me. Well, when I started practicing HIV medicine, I was already myself, as you have mentioned during the introduction, a person living with HIV. Because I've lived with HIV for over 30 years, 35 years, 30 to 35 years. And when I went to Melbourne, where I was caring for all the time people living with HIV, then I noticed there was a problem because we had received the great support from the people of the US through PEPFAR at around 2004. And we're getting free ARVs, which I myself gained from, because when I started swallowing ARVs, they're costing about $500 a month. So when I got this chance to get free ARVs, of course, paid for by the people of America, I felt so relieved. And so I encouraged more people to come and indeed be registered. But that's when I noticed that there was a group of people who were not doing as well as the others. And these were older people. Indeed, some of them were fairly depressed, and some refused to swallow ARVs. It took long for us to realize these were people having mental issues. And yet, the PEPFAR program could not allow us to buy medicine for them, using them. They just insisted we buy on the ARVs and anything to do with other things. Then later on, we discovered that some of them who were older, we even having diabetes, and some had, actually I remember a particular who had both diabetes and hypertension and was depressed. And we would write for them a long list of medicine to go and buy. And many of them said, look, even the money which brought me to come and pick the ARVs, I borrowed it. I sold the chicken to come here. And now you're giving me a list of drugs to buy. I don't think I want to swallow this medicine because they're just prolonging my suffering. And many of them, actually I need to make it, I can't go into detail, but quite a number gave up. Now, fast forward, when I started swallowing ARVs and my health improved around 2005, I lost my wife, I went back and remarried, started living like a normal person because, look, I was swallowing medicine well, and I was doing very well. My thyroid was suppressed, my CD4 count was high. Along the way, I noticed I had developed high blood pressure and had developed diabetes, especially when I was introduced on a new drug called dolutegravir. And that's when it dawned on me, I felt the pain this poor had. Okay, I can afford these medicines, but they're damn expensive, more expensive than ARVs, even those who had been buying ARVs. So that's when I thought, wow, we need to advocate for more. I remember my first time is when I was talking about this was, I think I met Ambassador Deborah Bucks, who was for the PEPFAR program. And I said, look, you should look at us as just containers of HIV. We are human beings and we have other things that we have. So a person who is depressed will not swallow ARVs. I remember as I finished, one of my patients saying, I wish, I mean, this is not a person who, this was another one, I think I'm mixing up, but somebody who did not have what? HIV, say, look, I wish I had HIV other than having this. But people who had HIV and had these diseases really looked at it as it's a big burden, especially in our country, where we cannot get even these medicines freely. So I thought we should look at the programs again, health programs, instead of focusing on diseases, focus on the person. And I think this is what has been. Currently, as I mentioned, myself, another person at 70, and I know that the next part of my life is going to be quite heavy because I cannot work the way I used to work, and therefore I have, but yet I have to buy these medicines. I thank you so much. That's my experience as a clinician, but also on a personal level. Thank you.
Thank you, Stephen. And really, your plea to be treated as a person and not just a disease. I mean, it not only resonates so powerfully, but it reminds me, and I'm sure many people listening today, of the emphasis on human dignity and human rights that brought about and that fueled the global AIDS movement, and that brought us PEPFAR. So it shouldn't be a big leap to use that powerful platform for human-centered integrated healthcare. And that's why we're really so fortunate to have you here, Katie Godfrey. PEPFAR provides so much of the context for the HIV response in Eastern Africa, where Chiri and Stephen come from. So over to you to hear about how you're thinking about aging in a PEPFAR context.
Hey, well, first of all, thank you very, very much for inviting me to this, and it's a real treat and honor to be joined by Dr. Kepligat and Dr. Watiti, whose path I've crossed over the years several times. Dr. Kepligat is a star in our field, and Dr. Watiti, I very often learn things from you every time I hear you speak. So thank you very much. I've actually prepared a presentation, which I'll stop my video and I'll share my screen. So the PEPFAR context, the first thing I wanted to mention is really to point out the global results for PEPFAR. There are 20 million people on ART on ART, and it's really a huge thing. That's more than that's just about half of the entire global burden of HIV/AIDS that is supported by PEPFAR on ART. And there's, you can see the information here, the 25 million lives saved, and babies born without HIV, and people who've had TB prevention therapy. So it's something really that I'm very proud of and very honored to be part of this effort. But let's think about some of those successes. Our data now, fiscal year 2022, almost a quarter of the people are over the age of 50, and half are over the age of 40. With any luck, those people who are over 40 will graduate to being over 50. And so it's really a population, it's really a growing population in our program. Varies a little bit from country to country. You can see that, for example, in Botswana, that almost a third of the people are over the age of 50. These little green bubbles are people who are over 50, and I've called out the numbers for you here. But in general, all across Africa, the population of people over the age of 50 is about a quarter. And this, as has been pointed out, this population is growing, and you can see the changes over time. And we have projections. I mean, and with the caveat that in the later projections are somewhat unstable. The data modeling is somewhat unstable. But I think it's fair to say that in some places where there have been successful programs, almost half the people by 2030 will be over the age of 50, and that really does change the sort of the trajectory of the program. So I'd like to talk about some of the various parts of our program, and let's start with HIV testing. Chiri and I shared a little chat. I see patients clinically, and on my medical ward round last weekend, actually, I took a sexual history that had never been taken in the 70-year-old woman, so which actually was relevant to her condition. So when you look at the people who are testing positive, we know that about 10% of people, you can see the people testing with positive HIV tests, positive HIV tests, about 10% of them are over the age of 50. And if you look at the sex distribution, it's really equal, men and women. And so what we know is that people over the age of 50 account for just about 10% of positive tests. Looking at the people who are newly initiated on treatment, you can see that, about 10% of new treatment initiations were in people over the age of 50, and you can see that here. So more people that test positive in the younger age groups, but this is still a significant number. And just to say a little bit more about that, these are people who are newly initiated on treatment, and this is it's a small number, but it really is significant. We're talking about 50,000 people in 2022 were newly initiated on treatment who are over the age of 50. So one of the things to say is that there is, if you look at this graph here, the gray line is people who have never been on, people with HIV who have never been on treatment. The blue line are people who with HIV who are on treatment, and the light blue line are people who have been previously on treatment. And and what you can see is that the people who have previously been on treatment but are not on treatment now is probably going to be more than the people who have never seen HIV treatment. So what I'm trying to get at there is that it isn't entirely clear to me that the people who are categorized as new on treatment have never seen our treatment programs. We just don't have good data about that. So just to underline what has been said, that has been said in the introduction, is that the older population of people living with HIV is quite diverse. There are people who are naive to treatment, whether they know their status or not, don't know their status. There are people who are living with HIV, but previously on treatment, not on treatment now, and those who are on have been on treatment for many years. So and I kind of feel that this is, the people living with HIV previously on treatment is a sort of an untapped group that we need to kind of address. And clearly that group is the challenge for the second and third 95s. So how do people on over 50 do on treatment? Well, pretty well, I think. So what this is what this is showing is how many people over 50 are virally suppressed. And just to be clear, to be eligible to have a viral load, you have to be on treatment for 6 months. So the bottom graph says, asks the question, if you're eligible to have a viral load, do you actually go and get one? And you can see that the purple is the people who are over 50. And you can see that people who are on treatment, they usually go and get their blood tests. And of those people, 97% of them were suppressed. So they get their blood tests and they are suppressed. So to me, that suggests that, their HIV is well controlled. Treatment interruptions are a little bit different now. So the graph on the left shows the absolute number of individuals with treatment interruptions. So these are numbers of total interruptions of people who interrupt their treatment and miss out on getting treated. But the important thing is that the percentage of people who are untrucked, so the percentage of the total cohort in that age group is on the right, and you can see that the men and women have the same sort of treatment interruptions. Maybe men a little bit more, but there is a significant amount in the over 50 age group. And just to talk a little bit more about that, so when we look at the age differences, we see that the pink represents people who interrupt treatment within the first 6 months of therapy, and you can see that across all ages and both sexes, that about 7 to 8% of people interrupt within the first 6 months of being on treatment. Now, I think that the reasons for interruptions within the first 6 months vary greatly in the different age groups. And I would put to you that the reason that an over 50-year-old person interrupts treatment in this bar right here is different than the reasons that somebody who is 20 to 25 interrupts treatment. So you can see this is the 20 to 24, and this is the over 50. It looks like my 0 came off of that 50. Sorry about that. So, but I think that that's actually really important. And you can see the sex differences here, that it's pretty consistent across both ages, all ages, and both sexes. So it seems to me that for people who have been established on treatment, it seems that men may interrupt more than women. The numbers aren't that stable, so I don't want to make a lot of that, but I think it's actually really important to underline that within the first 6 months of treatment, many people interrupt treatment, and the reasons for that may be different. So in terms of mortality, I think that as Dr. Watiti has pointed out, the mortality issues are different for people who are aging. I think that, so the top line is right now, this is South African data, and what it shows is that non-infectious deaths exceed infectious deaths as of somewhere around 2012. So I think that that's something that's really important to note. This is all comers, not just people living with HIV. And this is, again, all causes, all causes. I think what we can say is that, oh, sorry, I didn't mean to do that. I think we can say that the 7 of the top 10 causes of diseases, causes of death across the globe were non-communicable diseases. And it's a really important statistic. We looked at that in the PEPFAR context. The AFRICOS cohort is a longitudinal cohort run by the Department of Defense and supported by PEPFAR in 4 African countries. This slide shows that there's a significant burden of non-communicable diseases among people living with HIV in 4 African countries. We weren't able to show that that people with HIV had more non-communicable diseases. That's something that has been shown in resource-rich settings. But I think that the reason for that is that the sample size of people over the age of 50 was very small. Without HIV, it was very small. I'm not showing the data, but there wasn't a sex difference in the presence of comorbid conditions. And what I will say also is that we've done some prior work suggesting that obesity may be more prevalent in women with HIV in African countries. But I think it's important to say that it's age more than HIV were associated with non-communicable diseases. And there's real geographic heterogeneity of the non-communicable diseases. I'm sorry. So in terms of the sex differences through 2021, you can see that this is the proportion of individuals who have died over the age of 50. This is program data, and you can see that this is men in blue and women men in blue and women in yellow, and you can see that the mortality for men was higher across all quarters in the over 50 population. We think that the bump right here was likely related to COVID-19, and this and we were very reassured to see that this has evened out after the COVID-19 pandemic. So in summary, people over 50, I think, continue to be at risk for acquiring HIV. And my feeling is that prevention and testing services may need to adapt to accommodate this population. And people over 50 years of age experience high rates of early interruption in their first months of treatment. And I just wonder if age-sensitive services with holistic care may be helpful in ensuring treatment continuity. And I do think that interventions that address the unique challenges of older people living with HIV will improve continuity of treatment. I do think that the risk for HIV acquisition may be different in older women than postmenopausal women and then in perimenopausal women. And I will tell you that my clinical experience is that this is an area of important where counseling is very, very important. Older men also may have different risk behaviors than their younger peers, and that's another thing that has to be addressed in the testing environment. What I will say also is that we are committed to supporting and aligning resources for HIV care with national health programs. And I think that person-centered care really focuses on reducing mortality and improving what we call the health span. And that's the period of life spent in good health, free from the chronic diseases and aging-related disabilities. And this is an area that I know Chiri has been working on quite a lot. And I think it's a very, very, very important area for clinical medicine. And there is a growing body of evidence suggesting that treatment continuity improves with integrated care and NCD care, but I think that we have to really figure that out. And there are different service delivery models, and I don't think we know which one is the best one, but it's likely to be dependent on what's happening locally. I think PEPFAR is committed to working through the details of providing hypertension care, and that might be a pathfinder for how integrated services might be delivered. And with that, I will say thank you very much, and I do want to call out these people who helped me put these slides together. So I will stop my sharing now and go back on video.
Thank you. Thank you so much for that, Katie. You have put the stories that Chiri and Stephen shared not only into a PEPFAR context, but into a population context. This is clearly not just anecdotal. This is part of a macro phenomenon that is growing, that is going to force the need for greater health system adaptation in years to come. And thanks also for stating PEPFAR's commitment to aligning programs with national strategies and for grappling with the NCD issues and so on. Stephen Watiti, let's come back to you. I mean, so we have a sense of the scale of this. We are going to see more older patients with HIV, with comorbidities like yourself. You're a medical doctor delivering HIV and primary care in Uganda. What are some of the challenges that you anticipate for health providers where you are as you begin to adapt to some of these demographic changes?
Thank you. And I want to say thank you very much to Catherine for that presentation. I should have started by saying that if it wasn't for PEPFAR, I wouldn't be here in the first place. You know, when I was starting to sell ARVs, they were costing about $500. There was no way I'm going to sustain that. But when PEPFAR came, it's like I started living a new life. Thank you very much.
Certainly can't take responsibility. It looks like Dr.
Now, say, sort of my internet is a bit unstable. I hope you can hear me.
We hear you now.
Okay. Yeah, I was saying that the system is not prepared because, first of all, person-centered care means someone also has to be trained to do the work. Now, if you look at the people who are trained, if you go to any medical school in our countries, I'm sure it's the same in Kenya, you will not find geriatric specialists, people who care for older people. And so they treat older people the way they treat younger people. The same way children have been mistreated because people looked at them as small adults. And that is the same problem. And so it looks like we need to retrain people. We need to redesign our clinics. We need to look at these people, their needs keep changing, because the truth is that when I started doing HIV medicine, I was around 50, just over 50. Now, the way I look at myself, the way I feel is so different, just in a span of 20 years. And I can imagine in the next 20 years when maybe it will be what? So these are some of the challenges. The system doesn't work. And the fact that, for example, HIV-related stigma is quite a big problem, and it's bigger, especially in the older persons. The fact that this is a disease which sometimes looked at as a disease of young people or associated with sexual behavior. Now, most older people find it very difficult. And then when you go to any clinic, you'll find only young people who may not be able to appreciate what an older person is thinking. After treating them, giving them ARVs, they say, you go to the other line and you start lining up again to get not medicine, but a prescription from a specialist. So it's a big problem. So maybe we need to look at this again. I see problems as the numbers surge, because with the reducing deaths, a lot of people are going to get into the older age bracket. And these are people who are living with HIV. At least in my country, we have over 1.5 million people, possibly. So in the next 20 years, there will be over 1 million older people living with HIV who need these services. So we need to train now. We need to plan now. And we need to raise our voices. We thank God for and the people of America for the PEPFAR program, but we need to be supported to do advocacy with our own governments to be able to come on board and look at this in a proactive way, knowing that the numbers are going to keep increasing. Thank you.
Stephen, thank you. I'm going to ask you a follow-up question. You mentioned the stigma and discrimination against people with HIV, which I think intersects with ageism. And that I think points, as one of our participants, Laura Ferguson, has pointed out, to the need for interventions, not only within the health system, but outside the health system as well, within the community, at the level of policy. In addition to the health system changes, the need for geriatric training among HIV service providers, what kinds of changes would you like to see outside the health system to adapt to this demographic opportunity?
I think we need to look at HIV in a holistic way, looking at from different angles. Africa, especially my country, for example, they are very religious people, very religious. Never mind, we have our own challenges. So we need to look at how this, because most people listen to religious someone almost every week. So we need to give this information, because people cannot give what they don't have. So there must be information, correct information given to the right people who can then pass it on to the world. Because what changes, and we may have these ARVs, but unless people are given proper information with the treatment literacy, training, and then people come to and look at HIV not as a disease of shame, because many of the people who need these services may not be able to talk openly the way I'm talking or ask for help. Many of them, they know they have HIV, but they will not be able to ask openly for any help, mainly because of stigma associated with the disease. So health systems, yes, but the whole community needs to be educated. You know, when I went to the medical school, the slogan by WHO was health for all by the year 2000. I think we need to come up with a new slogan, or maybe if it is there, we emphasize it. Maybe is knowledge, health education for all. People living with HIV, yes, but the communities in which they live, because people don't live in isolation. I thank you.
Thanks. You know, Stephen, this issue you mentioned before of the lack of geriatric training and capacity among HIV service providers. Since you've been so generous in sharing your personal story, I want to share that that's a very personal issue for me as well. I'm a person living with HIV. I'm 48 years old, and it's by sheer coincidence that the doctor who provides me with HIV care happened to inherit his medical practice from a geriatrician in the 1980s. And for that reason, he also has geriatric expertise, which is very helpful to me as I get older, as I develop comorbidities, as I have a family history of heart disease. You know, this should not be a coincidence. This is so much the exception and not the rule, not only in low and middle income countries, but in high-income countries, in the United States, in Western Europe. And Chiri, I want to come to you because you have looked at this issue in a global context. You were the lead author of a very influential article in The Lancet that looked at the opportunity to integrate HIV care into a broader platform of person-centered holistic care in countries of different income levels, in PEPFAR supported countries, in wealthy countries with primarily private healthcare like the United States, and in wealthy countries with socialized medicine. So from that research perspective, what have you learned about the opportunities and challenges faced by countries of different income levels with different kinds of health systems to provide more integrated care to persons living and aging with HIV? Chiri.
Thank you again, Jonathan. Thank you, Catherine. Thank you, Aditi, for that sort of introduction that brings to the work that we've done in the past, specifically within the Lancet paper. And I want to encourage the audience today to, go to that paper. There are other 3 papers alongside that would be really useful to understand a lot about aging with HIV. And there is also some supplement with JADES related to aging with HIV as well that would be really great to read about. But back to what you asked, Jonathan, I think one of the key areas, and especially from the challenges perspective, and in all honesty, I would want to focus on the low and middle income countries, and these are focused on the PEPFAR funded for this purpose. There are opportunities that I see as leveraging on. One is that thanks to PEPFAR, we've had a very well-established infrastructure for HIV in the various PEPFAR-funded programs. It is, that infrastructure that could be leveraged to offer, NCD care and care that people aging with HIV could benefit from. And I say this because that infrastructure already have a well-established, supply chain management for commodities and drugs. If we have opportunities to leverage on that to get medication for NCDs, and I want to give an example of the AMPAT program specifically. The AMPAT program, leveraging support that they received through GCC, that's Grand Challenges Canada, and looked at opportunities of, having what they call a revolving fund pharmacy. A revolving fund pharmacy is a pharmacy that was set up and has been set up in the majority of the Western Kenya ART sites. Is a pharmacy that ensures that there is access and also affordable medicine for, comorbidities, hypertension, diabetes, and also mental health. So that if you have, patients who are living with HIV and diagnosed with these other comorbid conditions, they're able to access that medication. It may, it's not free medication. However, it is medication that is subsidized. I would say subsidized in a manner that, it's given to the patient at cost. There is no markup cost that is added to it. And as such, patients are able to work, and support through National Hospital Insurance Fund to be able to access that. Of course, not all the medication is affordable, but we have also engaged, had innovative ways within the program as well to ensure that our people living with HIV and even the community, the whole population, and that's something that AMPAT really pride itself, moving from just focusing on HIV to really looking at the total population in a manner that we are empowering the community to be able to support itself in terms of paying for their National Health Insurance Fund, so that they can be able to access the medication as and when they actually need it. That aside, I want to look at another opportunity that I think it's not just for, the PEPFAR funded, but can be applicable, is the issue related to universal health coverage. I think we've talked about this, WHO talks about this a lot. I believe moving, and there is a whole lot in relation to universal health coverage that really encompasses, access to health, affordable healthcare, that can ensure that, aging people with HIV would really have consistent access, but also a full range of services that are not currently accessible to them or not available to them. And this, not only the older people, but all the population can be able to access that, whether you're still at a younger age and are growing to that aging population, you can be able to access that. I bring, and I see this in where we categorize the three funding mechanisms, the government funded, the insurance fund, what we see a lot in the US, and what we see the dependency within the PEPFAR funded projects is that there is well-developed, medical record system, the EMR, that I think could be leveraged to ensure that it's not only just collecting HIV-related data, but also data related to other comorbidities. And that would ensure that we are able to monitor our patients over time, monitoring them for other conditions that they are suffering, even if they're receiving that care outside of the HIV clinics. As such, that would really be very helpful in ensuring that, our monitoring is not only focused on the 95, 95, 95, but we're looking at, the fourth 95, the healthy longevity, or, ensuring that as much as we achieve viral load suppression, we are also living healthy. And that component of living healthy is seeing, have I been diagnosed with hypertension, and am I, achieving hypertension control? Do I have diabetes, and am I achieving diabetes control, and all that? So leveraging the IT system and the medical record system and the social support, I think that is one very key one. And as I end, I want to talk about the task shifting. I think that is what has really come out to train people on geriatric care and offering geriatric support to our older patients. Thank you.
Thanks so much. And of course, we all
Jonathan, I wanted to just thank my neighbor. We're quite near each other here, though we haven't met, but I'm really excited the fact that she mentioned the issue of task shifting. Because when I remember the clinic we were running, there was supposed to be a physician coming to see this patient, and they would have to wait the whole day, and then he comes and sees them for about half a minute to write the medicine. It's when I realized that the importance of, especially for us in Africa, there is no way we're going to have those specialized geriatricians, but the service can be given by lower cadres who are given the information and being able to work with them, because we cannot wait until we get people with maybe masters, PhDs. They would be great, but we need to start, especially with task shifting and having people do this work, even when they don't have the papers. I thank you.
Thank you. I'm going to turn it back to Katie Godfrey just to react to the discussion that your great presentation has generated. Before I do that, I also want to elevate a really important comment that was sent to us about the importance of geriatric dentistry. Of course, part of holistic health is oral health that is intimately connected to the health of the whole person. So, as we think about PEPFAR as a platform for integrated care, we should be thinking about oral health as well. But Katie, just in the couple minutes we have left, there are obviously tremendous systems barriers to using the PEPFAR platform for geriatric care, whether that's national AIDS programs being separate from ministries of health, or just the lack of attention to geriatrics in policy and practice. How do you see the program grappling with some of those challenges in its next iteration? Just in a minute or two, if you could. Thanks.
Yeah, well, I actually think there's a couple of, I'd like to pick up on a couple of things that Shiri mentioned. One of them is this notion of a unified electronic medical record. And that, I have to say, I've practiced in a country for a while there that had a unified medical record where, and a single unique identifier for all individuals. And it really is, it was really sort of life-changing, really. It's very, very helpful indeed. In terms of the task shifting that has been mentioned, the other kind of point is that I think has been really embraced for adolescents and for children is this notion of a navigator, a patient care navigator that helps the individual kind of navigate from one specialty to another, that makes the appointments and these kinds of things. I actually think that that's actually that particular task is really important with for older adults, and when they have to maybe access multiple different services. So and figuring out, helping somebody to figure that out, the sort of social support networks, the social work services, the that's actually something that's really important for clinical care. So in the next iteration, I think that one of the big successes of PEPFAR is that we're getting to full treatment, the 395s by 2030, and I think that we really may get there. So I think it's an imagination exercise, that a visioning exercise, that we really do have to think about how does that look like? What does that look like in the next iteration? And is it, and what does integrated care that is owned by each of the countries really, what is that, how does that work? How does that work, and what is that, and what does that look like? I do agree that integrated care is, for older adults, this wraparound services is critical, and, training issues are real, but you don't have to be a physician to take a blood pressure. You don't have to be a physician to, look at cholesterol, and you don't even have to be a nurse for many of those things. So understanding what are the pieces, the pieces that are most important for a particular individual is really important. And there are some task shifting things that can happen. I just read a report of a clinic in Britain that had non-clinicians doing frailty assessments. And frailty is a kind of a complicated term, is a kind of a term that refers to multiple comorbidities in the same person, but and this is an approach that could actually be used and could be and could be implemented. But I think we don't know what the right combination of things is. So I think that is the work that Chiri's doing, kind of identifying what are the specific elements that are the most important, I think is really going to be key. So that research element is, I think, critical as well. Systems research element is critical. And I fully agree with you about the electronic medical record. It was, it was really transformative when it happened.
Well, thank you. Thank you so much to you. Thank you for that vision. I want to leave everyone with the idea of what Chiri mentioned of healthy longevity as the fourth 95. And hopefully that will lead to visioning processes of what that can look like in different contexts in different countries all over the world. We're going to put up a slide of our next event. Thank you one and all for coming. If you enjoyed this event, please consider joining us for our next event with Gladys Kalema-Zikusoka. And on behalf of all of us at the Institute on Inequalities in Global Health at USC, a warm thanks to all of our panelists for your expertise, your vision, your dialogue with each other, and thank you for coming, and enjoy the rest of your day.
Thank you. Thank you.
Bye-bye. Thank you.
Thank you.